glad that the year has finally come to a close. Of course, we still have a month to go, but I hope that you are in the same spirit and power like you started out during the first months. Now, my name is Carol Norman Tumwine, and we are here with Issues at Hand, where we talk about different issues, political, economics, regional, and everything affecting our societies, including educational and inspirational topics. Today, we are going to look at the medical world and what is happening there. Of course, the medical world in Uganda has come from afar, especially the doctors and health workers, and we have seen growth since a long time ago. We've seen growth of this particular sector, and right now, of course, we are somewhere, and we are looking forward to the betterment of this sector, but also the betterment of the people who work as the health workers. And of course, it is a very, very big topic, and we are going to look at it. But particularly, we are going to focus on the exportation of Ugandan health workers to address the issue of unemployment. As you are aware, we have universities that teach or that train the medical world. They train doctors, health workers, nurses, public health assistants, pharmacists, all the people, every kind of doctors every kind of medical workers in this sector. Now, of course, under there is where we have the Uganda Medical Association, which recently, of course, got a new leadership, and we are in studio with one of our leaders from there. His name is Dr. Kabweru Wilberforce, and he is the chairman, ethics and professionalism, and he is going to be telling us all about this association. However, let me first welcome him to studio. You're very welcome this morning.
Thank you very much, Madam Carol, for hosting me on Family TV, and we're also glad to be here. As already stated, my name is Dr. Kabweru Wilberforce. I'm a senior consultant surgeon, and I'm the chair ethics and professionalism on the new UMANEC that is started actually this year up to 2025.
Okay.
Yes.
Now, someone watching us might be wondering, are there able surgeons in Uganda, people who can do the job very, very well? What do you have to say about that?
Uganda actually produces some of the best doctors in the entire world. You remember Makerere University and the medical school in particular,
yes, was
already built here years ago in 1930s. And actually they have been producing good brains. So Uganda has very good records of training medical workers, and by the way, we are among the best.
Okay.
So wherever we go, actually we have hands-on, so we can deliver.
Okay.
And I think we have also seen in this country that actually we have looked after a number of patients, and actually if we, even as early as 1960s, when our former president Obote was shot at Kololo, he was managed in Mulago Hospital, wasn't taken out of the country. So I think we produce some of the best doctors in the entire world. Okay,
that is great. Then why do we have rampant, people flying out of the country to get heart surgery in India? You know, why is it like that?
Now, if we look at the scope of practice, there is what we call primary health care, and then also there is specialist services, and then super specialized services.
Okay.
So when you look at open heart surgery, that is at the extreme end.
Okay.
And probably we may not be having all the facilities. I'm saying all, but we have all the facilities that are available within the country. And then even when you look at the resources involved in actually providing some of the super specialized services, they are quite intense, and the government actually may be constrained. So somewhere there are services that we can't afford, but there are also a lot of services that actually we provide the entire country.
Okay. Thank you. Let's talk about the Uganda Medical Association. What exactly is the mandate of this association, and take us through the journey of achieving some of the goals of this mandate?
Yes, I couldn't say it is only one or two, but the number of things that were meant to deliver, but one of the most important things is one. Uganda Medical Association is meant to have a look at the quality of doctors that actually we provide to the entire country.
Okay.
But also the services that actually we also provide to the what? To the common person or mwananchi. So if I could say the mandate now is to provide actually health workers or doctors in particular that are going to provide services to the commonest person. So we actually feel like we should actually get doctors employed at a level of health under 3, because that will help in promoting service delivery to the commonest person in the lowest rural area. If you look at the, I would call it pandemic of doctors within Kampala, within just a blink of an eye, you can say doctor. But what about when you are in the village there? How many hours, days, weeks, months can you spend without seeing a doctor if you are meant to see one?
Okay.
Those are the questions that we want to answer.
All right. Thank you so much. Now, let's get to the statistics. How many doctors are absorbed in the employment sector, and then how many are on the streets? Also, what are we going to do to solve this problem? Because universities are still training doctors who are going to come out every year. So how can we work on that?
Actually, I will first allude on the fact that actually earlier on, or gone are the days when we had Makerere University as the solo university, medical university in the country. Now there are so many cropping universities, both government and private. And just to mention a few, we have Makerere, we have Gulu, Busitema, Mbarara, and we also have private universities like IU, KIU, and the others. And we don't know how many are in the pipeline, because things in Uganda, you can't put your leg there to be cut off, that anything won't prop up. So there are so many in the pipeline, which is very good, because at the end of the day, you realize that the more those universities come into play, actually the more health workers they produce per year. But currently, if I could speak about the doctors as one of the sections of the health workers or health care providers, you realize that actually currently Uganda produces around 900 doctors locally. Those are minus those ones that train from out and come and want to do their internship here. So what does it call? It means that as more universities crop up, we are going to have raising numbers of intern doctors. And at the end of the day, that would be, I would call that a low-hanging fruit, because just imagine the resources that you have put in this person for 5 years, and now it's ready just to get licensed. Because during internship, this is the period where someone is training on job, but learning a number of skills, knowledge, and practices, so that at the end of the day is given a license to work independently. So it is a very crucial period, and I think government has taken its responsibility to make sure that actually it facilitates interns to do their internship. But we would actually advocate for more facilitation, because if you look at what is being available or availed to most of the interns, is that, for instance, initially when I was doing my internship, we used to have accommodation, we used to have meals, and we used even to have all what we needed within the hospital. Now, when you look at the current structure, is that most interns actually, first of all, they are not accommodated in the facilities, not even close. It means they have to look for their own accommodation, and that pushes in another factor of transportation. And even now, they are not given meals. So if you just look on the basic minimum, you realize that an intern doctor needs to be over-facilitated, because even 1 million when you give them and they are renting a decent house of 400,000, and transport takes like 300,000, that's already 700. And then if they feed on the 300,000, at the end of the day, what will they use to actually use to get other services, like if they need the airtime or the rest? So we implore our government actually to make sure that actually the 2.5 million are given to interns, so that they also deliver. Because during that period we are training or supervising interns, actually they work 24 hours. They are not meant to be away. So if challenges come that we are not accommodating them in the facility, they have to transport themselves, they have to feed themselves, then it becomes a very big challenge, a dilemma that actually we cannot make them stay on 24 hours on call. They have to work like a public servant 8 hours, and you let them go and rest in time, or even to go, they are pushed to other levels to do other things. So the government should get intentional in making sure that actually it facilitates them and they do the best job. And after their internship, we implore government actually to employ these doctors because they are readily available. It's a big resource. One of the biggest things I would say that most of the facilities from specialized hospitals, national hospitals, regional hospital, and then health center 4s and worse to health center 3s, they don't have doctors. The doctors are quite very few in there because of understaffing. You know that if you have employees, there is always that attrition, factors that cause attrition. And one of them, which we know, East and the West, retirement. People retire.
Yeah.
People die. People move on. We call it a brain drain. And then the other thing that also people move from public service to government or other NGOs.
Okay.
So they create always those gaps that need always to be filled year in, year out. So I would implore our government to use that and employ doctors as best as they can up to Health Center 3. And I think service care system will improve much because one of the biggest resources is human resource. Even when you have very good infrastructure, you have to have human resource because that is the most difficult. Just imagine how many billions you put into training this person 5 years, and then you leave them on the street, and then they are there and they can't actually. It's not employing more than 40% in some of the facilities. I know if you did your local statistics, you realize that there is severe understaffing.
So the problem of the budget is a huge one. Let's talk about the budget for the Ministry of Health, particularly this particular financial year, which was about 10% of what you expected. How, first of all, are you going to fill in the gaps of the money that was not given to you? But also, how is this 10% going to help in solving some of the challenges that are available?
That's a very big question to me. The PS has a very big answer, is my boss. But I just want to answer in a different dimension. That actually every time there are budget cuts, they have a lot of impact on the service delivery that actually will be given to the common person, especially patients who come to the public facilities. So the working environment becomes difficult. What do I say the working environment? For instance, if you look at medical supplies and health supplies that will be delivered on the same small budget that has been cut, they become a very big challenge because the government actually is buying the things to make sure they are delivered in those facilities. So if you continue cutting the budget, it means you're also reducing the amount of drugs, the amount of health supplies each patient is going to get in the facility. And actually that causes a lot of dilemma because some of the services may either be partially be provided or not completely provided. And that actually impedes a lot on how the population grows. Because if you have most of your population sick and they cannot afford the health services, it means they are going to be less productive. So at the end of the day, the government actually loses out. For instance, if someone walked to Mulago and needed paracetamol, that's Panadol and Coatem, and the budget was more already cut, that means those drugs that would have been benefited like 100 people would benefit like 50. Then the big question comes, where do the other 50 go? So at the end of the day, it impacts a lot. Those people, the 50 who have missed out, you realize that they may actually encroach on their household finances to chip in. What about if they cannot afford? Some of those patients actually, they end up dying or being sick for a long time and then losing out on their productivity days or weeks or months. And that has a lot to do with the reduction in terms of productivity for the entire country. So it will impinge on the economic growth of the country at the long run.
Okay. Okay, so let's talk about the exploitation of healthcare providers, like our topic was saying. What is the plan for the exploitation? Is there a strategy that the association has, or even the health sector has, to make sure that the doctors in Uganda are exported to comfortable countries and also get our benefit from their work?
Okay. First and foremost, I want to say that actually doctors have been going. If you go to any other country, even US, even in South Africa, Middle East, you realize that actually you reach there and you find Ugandan doctors there, already in Australia. And this actually doesn't actually start here only. You know, there are doctors who have joined most of those systems from HSC, that is senior 6. They pass and they move on either to Canada or US or UK or Middle East or South Africa to continue their studies. And when they excel well, they actually remain in those countries. But the question here is, we as Uganda Medical Association, I think as big stakeholders, because we have a very big number of doctors, almost close to 8,000 doctors, both here and then in the diaspora. So if we now talk about exporting doctors, I think it does very well when we work out with the government and the different councils, and we have companies that export doctors. It actually benefits the entire country in two folds. One, the companies that register to export doctors actually will be paying taxes.
Okay.
So even those doctors that are exported, they will be able to pay taxes to the country. They may be probably around 30-40%, but also it helps the association to technically get involved and see which countries, because there are countries that actually don't have medical schools, and that impinges the route. I will just give an example. Like South Sudan may be having a few medical schools because it was a war-torn country for some time.
Okay.
But now they are big neighbors, and if we don't take doctors there, that means they will keep coming here as refugees and whatsoever. Congo, there always was here. They have medical schools, but we train also their doctors. And if we can take some of our doctors there who are on the streets, that becomes advantageous because they will go to earn, and the government will earn something in terms of taxes, but also the doctors will be at work and then be able to live a probably facilitated life, because it is also unfortunate that if you train your child for 5 years and at the end of the day he doesn't get employment, it strains the family because you have been using resources and there's no way to recapitulate on those resources back. So I think it is the high time that actually Uganda Medical Association gets in touch with other associations of those different countries, and we give them that human resource that is readily available.
Okay. So if these doctors indeed go to these countries, will there be a follow-up?
Yeah, there will be a follow-up because Uganda Medical Association actually, it is not a one-time thing. It has been a mother association for a long time, and it has usually that supervisory role. Even here, actually, even advocacy, because at the end of the day, in those countries where you're going, actually, Uganda Medical Association has a higher say, because there will be MOUs, memorandum of understandings, that will be reached, and we can easily follow up, because that becomes a little easier for them to negotiate than an individual. So I feel like we shall have that extra responsibility to follow up and make sure that actually our doctors are safe, and they also doing what they are obliged to do, their responsibility, and they actually catered for in terms of their remuneration and the other services that they are entitled to.
Okay, so will this exportation indeed solve the challenge of unemployment that is still a big problem?
Sometimes you can't say one size fits all, but exportation of doctors can also go a long way to reduce on the number of people who are not employed by government. But we shall actually emphasize and say, since our country is still developing, and we have a big population that is always, actually, we have a very increasing growth rate in the entire country. And before even a child is born, needs care when he's intrauterine. And we have doctors that are on the streets, and we have facilities that are not yet well staffed in terms of health care providers. So I would employ that actually government employs most of the doctors, and then the others who are not employed actually, and they also not offering services in private, they get exported. And I think it can solve, it can give a cutting edge on the people who are on the streets and not employed.
Okay. How about the training policy? Do you think that we have a strong training policy, or is there a vacuum in that area?
I wouldn't say a vacuum. Sometimes you can't know when things are in the process. But I think that has a good opinion. Because if we had a training policy beyond UPE, USE, and now at university, I've already stated this earlier, that a training policy would actually sort out the issues we are going through.
Okay.
Because when you have a training policy, you actually put mechanisms about the institutions. For instance, the private medical universities and the government medical universities. You would actually budget for them appropriately and say, we are going to admit this number of students. This is the cutoff entry points. And these are their, what we call clinical placement sites, or where they are meant to be training from. And you are able to go and even supervise, equip them, and make sure that they have even appropriate labs where people are going to train. They can access patients, they can access supplies to use when they are managing patients, and they can actually even have their lectures and their people who are going to train them, and also pass on the skill, knowledge, and better practices, so that at the end of the day, things don't just come suddenly that, hey, we have 1,000 intern doctors. I had budgeted for 400. So it helps for you to budget what you can swallow, and you actually employ that policy. What you have trained is what you're going to budget for, and then you don't need to keep other people waiting for slots to come for internship. Because at the end of the day, if for instance we have the 900 locally trained, what about if you had the 100 that came from abroad, and it makes 1,000, and out of 1,000 you can only actually cater for 400? What happens to the 600? When they become cumulative every year, they become a very big challenge. That's why you hear industrial action and other things, and then people raising up to think as if they are not being catered for by their mother country. So I think a training policy will go around to actually monitor and plan for the internships, and even the residents. The residents are very important key people, because the senior house officers actually are on the ground. As they are doing their training, they are doing three things. They are learning, but also providing a service. And I've stated this, that as they learn and provide the service, they're also doing a lot of research for this country. So most of this research would even help in making policies for the country. Two, they are giving a service. For instance, me, I teach residents in surgery, apart from the undergraduates, but the residents, they already, even now as I speak, they're already in theater working, and when I leave here, I'm going to join them. So they're already providing a service, so the country shouldn't look at them as mere students. The moment you start grading people, students, and even pay interns the same, SHO the same, even someone doing a PhD the same, then it means that actually the policy that doesn't stipulate. Whereas if it's stipulated, you would know what kind of student you are dealing with, what he can offer, and what you as a government can gain. And if you don't answer their questions, then it means those people, after their training, they can as well go wherever they want. So it becomes also a big challenge to the country not realize the good in what it is producing.
So you're trying to say that the government has no idea how many students...
that is overstating. It has an idea. It knows. It is aware. It is aware that actually 900 interns are produced by year. They are very much aware. But when it comes to budget, then the budget, they are budgeted for the allowances. Whereas if the government came out with a training policy and said, fine, if we are going to train intern doctors, after they are undergraduate, we are going to put them in different training sites, and the public service should actually know that it gives these people terms and employ them for a year, because those internship is usually for 1 year. And then for the residents, the clinical trainings are usually 3 years to 4.
Okay.
So you plan and say, the moment you are admitted in Mulago as a resident, you're going to be paid for 4 years, and you're budgeted for. So actually the government wouldn't be struggling that the allowances have disappeared, the allowances are not coming, the allowances are somewhere there. Actually here it would be just on the system. Finance would at the end of the month send its money to public service, and then this will be sorted out. And life would actually be calm to the lowest level that you not even hear doctors complaining anyway. But you just see the services deliveries just flowing smoothly at the end of the day.
Okay, let's talk about the protection of doctors' rights. Are doctors comfortable in this country with rights protecting them?
I think at the end of the day, rights is quite a wide field. But I think there are some rights that are actually protected, but there are some that I think they are not. But all in all, I would say they are protected. For instance, I just want to pick a small book called the Patient's Charter.
Okay. The
Patient's Charter actually stipulates the doctor's responsibilities, obligations towards the patient. And the government puts those facilities to make sure that actually the doctor is well trained, registered, and is going to look after patients. And if you look at the Constitution, actually protects rights, protects everybody, irrespective of whatever category, maybe the doctor or somebody. So I would say that, yeah, they are protected. But then I think there are some that are somehow, I think that may not be attended to, because there are some of these issues that we know that even remuneration, because if you employ a doctor and he knows that in the next or in the neighborhood the doctor is being paid heavily, then he also feels like I should be paid equally good, like my colleague is like in Kenya or Rwanda or somewhere. So they feel like somehow, somewhere they may not be attended to. But by and large, I think generally rights are protected, apart from those few scenarios that happen. And then even employment, because if you train somebody and then you leave them there, why did you train them? They start asking themselves a number of questions. Shouldn't they offer the service that they have been spending time at school to offer?
Wow. So as the Uganda Medical Association, what is your strategy in solving some of these challenges we've been talking about?
Yeah, some of the things we have already alluded to, that actually most of the people who are trained should be absorbed. And I will insist that actually government has capacity to employ all the doctors if it makes that decision. And we would probably employ government not to have ceiling. What do I mean ceiling? Because sometimes you realize that actually someone has retired, someone has died, but people have not been replaced. And then the other thing that I should also employ our government to do is what they call automatic promotions. In a country like Kenya, I'm not comparing Uganda and Kenya, but I'm just stating, because this is read all over, and then usually it is automatic. If you have been at a certain level, your medical officer at level for 3 years, your promotion comes automatically, and then also your remuneration improves, and people are very motivated. Even here, when the president said, let our salaries be increased, surely we became very happy. And we said, if that can always be on the move and an increase now and then, it would actually solve a lot of things. And we feel like the government should employ doctors, recruit them the moment they are done with their studies, promote them, because when you promote somebody, he becomes motivated and he will deliver. And I've heard also something that people think that doctors, after increasing I read it somewhere in the papers, after increasing their pay, they started investing in things and they're not working. Literally, do I have rest in Mulago? Because Monday I'm in theater, Tuesday Major would round, I teach and then also see patients and answer consultations. Wednesday I'm back in theater because the patients are many. And then Thursday you see clinics, you run the clinic. Friday, like today, we are back in theater. And you literally, even weekend, you come, you're on call. So there are people who don't rest in this country. And I feel like they shouldn't be washed under the carpet that actually people don't work. No, I know there are some who don't work. I wouldn't say that we are holy and everybody works like we do. But I know those ones whose salary was increased, they should also know that actually they have to what? They have to work. And as the Uganda Medical Association, we say, we come out with strong force and say, please, if the government has enhanced your pay, you work properly, deliver service. Don't leave public service and you are being paid, and at the end of the month you pocket the government money and you have not worked. That is not being accountable. For us, we shall come also and also land on you and actually ask you to, if it means pay back the government money. If you're not seeing patients, you're not doing what you're meant to do, please don't take the government money. Tell them to employ somebody and then you continue with your business. But if they have employed you, just comply with the terms and conditions. After all, government asks for a few hours. But I usually don't follow those few hours because me, I look at the patient.
Yeah.
Even when it becomes midnight and I've started operation at 9, I will continue until the patient is safe. But if the government asks for just 8 hours, I always insist that the other 16 hours are free. In the night, it doesn't stop you from making sure you do your work. But let us deliver what the government has paid for properly, and also we go, because it is also morally it is right and ethically is right. You don't pocket people's money and then just walk away. Let us do what we are meant to do, our responsibilities, obligations towards the patient, towards the community, and towards the society we live in.
Thank you so much. We are going to take a very short break. We are still with Dr. Kaweru Wilberforce, Chairman, Ethics and Professionalism on the Uganda Medical Association. We will be right back. We are powered by Protea Hotel by Marriott Entebbe, comfort and luxury at its best.
Issues at hand, powered by
Protea Hotel by Marriott Entebbe, comfort and luxury at its best.
This is Church of Uganda Family TV, enriching lives. This is Church of Uganda Family TV, enriching lives. Issues at hand, powered by
Protea Hotel by Marriott Entebbe. Comfort and luxury at its best.
We are proud and honored to be sponsored by Protea Hotel by Marriott Entebbe. Welcome back to Issues at Hand. My name is Carol Tumwine. We are still going on with the discussion. Now, remember, the discussion is also ongoing on our YouTube, where we are live, but also other social media platforms like Twitter, Facebook, Instagram at Church of Uganda Family TV. Please go like, share, and comment what you think about this particular discussion. We are still talking about doctors and the comfortability. Are they very, very comfortable in Uganda and in their work environments? Also, the challenges facing the medical world and how exactly we can mitigate these challenges to make sure that we have a better Uganda. Now, of course, my guest in studio is Dr. Kabweru Wilberforce, Chairman Ethics and Professionalism, but also a senior surgeon in the country. My first question, as we get back to the discussion, would be, are doctors doing their job, or there are some ghost doctors, just like we had ghost teachers at some point? You may find that there are those particular doctors who are dodging their job. And how is the association planning to get these doctors and put them back in line, or maybe ask them out of the profession?
Thank you very much. That is quite very interesting. Whether they are ghost doctors. The simplest answer is that I really don't know whether they are ghost doctors. But sometimes I read the papers, and then you listen into the committee in parliament, and they tell you in a certain region they found 14 health facilities that were ghost with 59 doctors that were ghost. Probably it does happen, but that is not at my stake, because as a doctor, I may not know those details. But people who usually prepare payrolls and whatsoever, they may be having a lot of details, because at the end of the day I ask myself, before I pay you, I should know where you're located, what you're doing, and then for how long, and then when you are most likely to retire. So that is a very simple thing to do. But that is the work of somebody. But me, as a person, I will answer the other question. Are doctors doing what they are meant to do? I want to retaliate a bit and say, people who wake up in the morning, go to school in their secondary, primary, and make up their mind they want to become doctors, or if they develop that passion from childhood and they feel they want to care for the others, even when they become doctors, they always deliver. And that actually may not impinge much on their attitude. But they realize that also there are doctors who come to work and actually they are present, or what they call a presentism, but not doing what they are meant to do. That is a very big dilemma. They may come available, but they are not doing what they are meant to do. You find them, they have not seen patients. You realize they have not done a ward round. They have not been in theater. I know doctors, as per se, we have a lot we deliver in the hospital. For instance, I will state that a doctor reaches hospital, there are a number of things he's meant to work on. One, the primary role is patient's care. Either you see outpatient or inpatient, patients who are admitted, or patients that have been consulted within or even outside. Two, you actually meant to be conducting research. Because at the end of the day, if you don't do operational research or other research, you always have questions. Why is this not working? Three, doctors are also managers. We have units we manage, we have departments, we have divisions, and sometimes even the hospital at large, because we are the sole owner of the health products. So if we don't take charge of them, then at the end of the day, the public cannot have anything delivered to them. But also we carry on leadership. Like now I'm doing my leadership responsibility in UMA. I have to stay and then guide the rest of the entire team. They send us to serve. But we serve the public and serve their interests as well. So doctors do a number of things, but their availability at work should be key and it should be purposed. If you're not going to work, don't go. I usually say it is very unfortunate that you leave home and you're going to work, and then you appear at work and you actually don't do what you're meant to do. Then why didn't you stay at home and say I'm absent? Yes, although I've also had reports that there are doctors also who absentee themselves from work. I've said that and categorically stated that if you feel like you're not going to be at your workstation, don't withdraw the money, government money from ATM. You leave the money, let them pay somebody who is going to work, for you be busy being absent and doing other things, and let the doctors who are serious to work withdraw the money and work.
Okay.
Yes.
Thank you for that. Now, let's talk about medical care in Uganda. But I'm sure I even know other countries, but specifically for Uganda, because I've seen reports, medical care is very, very expensive. And there's a situation where you are very sick, probably it's an emergency, but you reach hospital and the doctors can't touch you without you having to dish out some money. And we're seeing cases where even cancer patients are facing a lot of expenses. Why is medical care expensive, and is there a way to solve this challenge? Because not everybody can afford.
I want to first of all thank the government of Uganda.
Okay.
That one, as much as government, as much as the costs of care are quite high on the other side, but the government has done what we call fundamental basics. One, it has put up a number of infrastructures, a number of hospitals, and then at whatever level, from the lowest to the highest. Okay. And in this country now, these days, we have some specialized hospitals. And then we have national referrals. It's no longer Mulago alone that is a national referral. There are so many that are coming up, and they're already available, and they are delivering. And the government has not only built those structures, but also it has gone along to even put in health workers. Although the numbers are low, but it is still improving. But there's something. And then it goes along also to provide for the medical supplies and medicines, which is very key. The budget, that's why we started with the budget. We started with the budget cuts. They affect a lot because the government has to deliver. But we should remember that the biggest consumers, and then even people who are paying, is not the government. At least 60% people pay out of pocket. So that is quite high. But even in those developed countries, you realize that actually the so-called health service products are quite very expensive. For instance, if you wanted to fix your chest, the requirements are quite a number. And that means that the government sometimes cannot provide. It provides the basics, but those super specialized requirements and services become a little expensive. And I think you have been hearing about the organ donation and the organ transplant bill, and then what is needed. Sometimes to take off like such a project is very damn expensive. But from infrastructure, training, services, and whatsoever, you are going to look after patients even after the surgeries. So it becomes a very expensive venture world over. Now, what would be the best idea or the best ideology on which we could help government also to make sure that it delivers those extra costly services? One, if we advocate for a national insurance policy, it will be very important. But what does it state? That everybody in Uganda has to contribute towards it. And I've been reading in papers that everybody will contribute like 15,000 shillings per year. I think that is very good, and I think it can be affordable. And if everybody can't afford, at least the rich will help even the poor to afford. If we pull that kind of money, then we can pull the cost a little lower. But it doesn't mean that actually we are getting it because it is at a low cost. No, we have pulled the resources to make sure that we can afford the service, which is very good. So that one can be one of the venture. I know there are people who are getting insurance, medical insurances covers under different dockets. But if it is now for the entire country, then it becomes a little easier, and we can pull the costs a little lower. Okay. Now, in times of emergencies, we had the COVID here and Ebola. Those actually strain a lot, and they strain the health care system. And in case we have lost health care providers, it even worsens, because training one doctor takes a lot of money. If you lose, the country doesn't lose alone, the entire world loses, because that person sometimes has skills that cannot be replaced in the next few months, years, and centuries. So it is always very good to make sure that we work as a team, we put resources, and make sure even the inadequate doctors we have, we improve on them, and then other cadres also available.
Okay.
And I want to say this, that it is not only expensive for you. You have had doctors falling sick, and we go along to solicit for them money. We also provide a service that we can't afford. That is very unfortunate. So it should not be that we really don't want to afford, but the government has put what it can, but because we lack some of those policies like insurances where you pay annual or monthly premiums to make sure by the time you fall sick you have something you have saved to cater for you.
Okay.
So it becomes a very big dilemma even to us, the provider themselves.
Thank you. Let's talk about the quality of medicine that Ugandans consume. You hear that medicine is from Kenya, India, UK, and does even Uganda have capacity to manufacture its own medicine? Tell us about the quality of medicine generally.
That's a very big question. It would be asked to the people who are registering companies that manufacture drugs. But I want to implore you and say, the country has some industries that make drugs. You have heard of Cipra. They are making ARVs. There is some Panadol that is made within the country. IV fluids, they are made alongside Ginger Road.
Okay.
And then Rene Pharmacy they make, and then even others that I don't know. So we have actually moved a step. Uganda is becoming industrialized, slowly by slowly, and we shall reach there. And I think even there are other industries that actually flagged off by the president to start making vaccines.
Okay.
And I think the Minister of Science, Innovation and Technology should answer that question, and the PS and the Minister of Health.
Okay.
Yeah, because they know what is in the docket, even in the pipelines that we don't know. But I think we have moved ahead. Then now when it comes to the quality of drugs in Uganda, that is a question that goes to NDA. But you have heard of what they were saying recently in the papers, that actually some of the drugs are not being used for the right thing, because the quality may be good, but for you have a cough, you take an anti-malarial. So at the end of the day, you are not using the right drug for the right condition. And if you get malaria that time when you have been exposing yourself to malaria without the treatment, sometimes you end up developing resistance. And we also know that some of the drugs are just because of the free policy. They call it the free economy policy, whereby you go and buy and sell what you want. I think there are some drugs that are not meant to be sold over the counter unless if they are prescribed or prescription drugs. For instance, most of the opioids, you have had people actually abusing those drugs because they feel like they have pain and constantly get in the mood of using those drugs, and they end up becoming drug addicts and then misusing the drugs or abusing them, and sometimes the complications are quite enormous and people have died. We have lost people, but also we have also heard that the resistance patterns keep increasing, and I think this is the next pandemic, because you reach somewhere and we do tests and the amoxicillin is no longer working because you have been using it for the wrong purpose. Sometimes you have flu, use an antibiotic which is amoxicillin. Your birds at home fall sick, get flu, you get amoxicillin to give them. Your animals, you fall sick, you give them ARVs because you want them to get. So sometimes some of these drugs are losing their potency because you misappropriating. I'm meaning those ones who are using for the wrong things. Okay. So somewhere the quality may be fine, but we are not using them for the appropriate good. But also that does not rule out the possibility that there are some counterfeit drugs. Because in a free economy, what do you expect?
Of course. If
you have a quality of cassava that comes on the market, sometimes it may not be the same. So the same applies to some of the medication and supplies.
Okay.
Yes.
I'll end with this. Is this statement true that an apple a day keeps the doctor away?
Which one?
An apple a day keeps the doctor away. Like if what you eat actually reflects your health.
What do you mean? That doctors eat well and then they do?
No. That if you eat apples every day, if
So
you eat fruits and vegetables, you won't need to see the doctor.
Now preventive medicine. Prevention, actually, for us, we stated different. Prevention is better than cure. Actually, if you look after your health very well, by taking a balanced diet, what does it entail? It has a number of constituents. If you have proteins in appropriate dosages, you have vegetables which have minerals, you have fruits with minerals, and then you have carbohydrates that in appropriate dosages. I think that goes a long way to keep you safer. But also we know that if you have preventive measures, for instance, if you know that when a mosquito bites me, I'm going to get malaria. So what you do, you make sure you sleep in a mosquito net that is treated, and then you clear the bushes where the mosquitoes are going to hide in the evenings before they come into the house. But also you clean away the waters that actually where mosquitoes in most cases hatch eggs and then they lay and they hatch eggs. So prevention actually is better than cure. So if you appropriately feed yourself very well, you will keep away from coming in the hospital for a long time, if not forever.
Oh, interesting. Thank you so much, Dr. Kawere Wilberforce, for your time. We thank you for coming to enlighten our viewers, and we do hope that next time you will join us as well. So thank you so much for our viewers out there who have been watching, especially those following on social media. I send greetings to you. Thank you so much for keeping the conversation going. You can like and share with your friends and family so they can also enjoy the discussion. My name is Carol Tumwine, and until next week, myself and the production crew say good morning.
Issues at Hand, powered by
Protea Hotel by Marriott Entebbe. Comfort and luxury at its best.